So, as mentioned, I worked for 12 years in Vancouver's downtown east side with a population that's known in North America as the most concentrated, densely populated area of addiction anywhere. Within a few square block radius, we have thousands of drug users, the open-air drug market in the streets, the needles, the injections in the back alleys, and so on. Even now, people find it shocking to visit there. So I worked there for 12 years, including for 2 years, as was mentioned, at the supervised injection site. Now, if one's success as a physician is to be measured by the longevity of his patients, then you might say that I was quite a failure in my last 12 years as a doctor, because my patients died young. They died of HIV and its complications, of course, especially since their drug use made their HIV treatment very, sometimes quite intermittent. They died of suicide, of overdoses, of complications of injection-borne diseases, abscesses of their brains, spinal cords, heart valves, and so on. So the second chapter of my book, In the Realm of Hungry Ghosts, opens at a funeral home. I won't read you much from the chapter, except this is of a patient who was 35. Her name is Shannon, and she, having stayed 6 months at a rehab home, or several months at least, something snapped. She came back to the downtown east side, and within a couple of months was found dead of an overdose. And after the funeral, we meet in a parking lot. I look at this small cluster of human beings gathered at the funeral of a comrade who met her death in her mid-30s. How powerful the addiction, I think, that not all the physical disease and pain and psychological torment can shake loose its lethal hold on their souls. Nothing sways them from their habit, not illness, not the sacrifice of all love and relationship, not the loss of all earthly goods, not the crushing of their dignity, not the fear of dying. The drive is that relentless. How to understand the death grip of drug addiction? What keeps Penny injecting after the spinal suppuration that nearly made her paraplegic? Why can't Beverly give up shooting cocaine despite the HIV, the recurring abscesses I've had to drain on her body, and the joint infections that repeatedly put her in hospital? What could have drawn Shannon back to the downtown east side and her suicidal habit and her 6 months getaway? How does she shrug off the deterrence of HIV and hepatitis, a crippling bone infection, and the chronic, burning, piercing pain of exposed nerve endings owing to an unhealing ulcer on her leg? Now, the societal answer to that question as to what addiction is all about is basically that it's a problem of choice. People just choose to do drugs. They choose to do drugs because they're ignorant, because they're ethically flawed, morally deficient, or stupid. But it's a choice they make. If you think that something is a conscious choice that somebody makes, then how are you going to stop them? Well, you're going to stop them by deterring them. How are you going to deter them? By means of punishments. So the Canadian government is dedicated to the draconian punishments of drug addicts. As you know, they just introduced laws that make it much tougher on drug addicts now for growing 6 marijuana plants. Just as Uruguay is now bringing in legislation to allow people to grow their own marijuana and to tax it and to market it. So Canada is making it increasingly punitive to possess drugs, and if apparently according to new legislation, if you're a party and you pass somebody a marijuana joint, you can be accused of trafficking. And the mandatory sentences for drug possession are going up and up and up. Judges and prosecutors have less latitude now to plea bargain or to exercise clemency. The result of which, that in a society that has less and less money for social services, less and less money for culture, less and less money to protect the environment, we're spending billions of dollars on building more jails and keeping people in jail longer, all because we think that addiction is a matter of choice. Now, the other hypothesis when it comes to addictions is the more of the disease model. Addictions, this model would have it, is a disease of the brain. And as to when it comes to the causation of the disease, what we're looking at is the genetic causes. So that alcoholism, drug addiction, and so are nicotine addiction, and so on. These are largely determined by genes. So this hypothesis would have it. Now, that addictions represent the disease of the brain is certainly valid. You can show that on brain scans and all kinds of biochemical assays. The addicted brain is a diseased brain. However, the assumption that this is genetic, and certainly that looking at it as a disease is more humane and offers at least the imperative of treating people, which the choice hypothesis does not. But what the choice hypothesis and the genetic hypothesis do have in common is a powerful ideological comfort. Because if something is a matter of individual choice on the one hand, or on the other hand, it's because of some gene that they inherited, then we don't have to look at social conditions. We don't have to look at the social conditions that engender addictive behaviors. We don't have to look at how children are treated. We don't have to look at what happens to pregnant women. We don't have to look at what happened in this country to the Aboriginal population, which has some of the world's highest rates of addiction. This is despite the fact that there were substances in North America that were potentially addictive before the coming of the Caucasians, such as tobacco, such as peyote, such as psychedelic mushrooms, such as other plants, such as alcoholic spirits in some areas of North America. But there was no history of addiction. If these problems were purely genetic or matters of choice, why wasn't there addiction before? And yet now, our First Nations population is dying at much higher rates than the rest of the population. They're incarcerated much more. In the downtown east side of Vancouver, 30% of my clients were First Nations origin. They only make up 20% of the Canadian population. Well, if addiction is a choice or a genetic disease, we don't have to look at any of that stuff. So it's very, very convenient. Which brings me to say about medicine, that we think of medicine as a science and perhaps as an art. Yes, it's both of those things, but it's also an ideology. It's a way of looking at the world. It's a way of understanding human beings. And the ideology of modern medicine reflects the ideology of mainstream society. And so that the idea of separating people from their emotions from their bodies follows from the needs of a society that has to exploit people's physical labor without any care for their emotional states. Because in this society, you can't care about people's emotional states, because if you did, you'd have to make very different economic decisions than you're making right now. So you separate the two. And similarly, a society that celebrates individual enterprise and individual success at the expense of the others, it's dog-eat-dog kind of mentality. We can't be looking at people's social relationships and the necessary interconnection and the need for love. So that separation of mind-body and separation of environment, psychosocial environment, from the physiology of individuals is not a scientific perspective. It's an ideological one. It's an ideological perspective that completely ignores the science. That's the nature of ideology, is that it doesn't let the facts penetrate. It doesn't let the facts penetrate because the facts would threaten it only admits those facts that doesn't threaten the ideology. And those facts that would undermine or call into question the ideological perspectives are not, they don't come into the equation at all. They, in the words of Mr. Spock, they just don't compute. So there's a lot of realities in this world that in the minds of decision makers just don't compute. Now, if we look at addictions more closely, what do we see? Well, remember I talked about adaptations. Well, when I was diagnosed with ADHD, I was given dexedrine, which elevated, what does dexedrine do, by the way? It elevates the level of dopamine in the brain, dopamine being an essential brain chemical particularly for incentive and motivation, and I'll tell you more about dopamine in a little while. What else elevates dopamine? Any stimulant does. Caffeine does. Crystal meth does. Cocaine does. Nicotine does. And that means that if for some reason your brain is deficient of dopamine, when you do caffeine, nicotine, cocaine, or crystal meth, you're going to feel really good, really alive, really vital. So that I know that in the downtown east side, probably 30% of my clients addicted to these stimulants actually have ADHD. In fact, they would even tell you, hey doc, I don't get it, but most people when they do cocaine or crystal meth, they get all hyper, but me, I calm down. And I clean my room. And what they're telling me on a gold platter is, here's my diagnosis, doc, it's ADHD. But they don't know that. They're just self-medicating. So addictions, I'm submitting to you, are in almost all cases self-medications. What else do people self-medicate? They self-medicate depression. If you've taken Prozac, like I have for depression, as an SSRI, selective serotonin uptake inhibitor, elevates the level of this important brain chemical between the nerve cells, elevates mood. But you know what else blocks the uptake of serotonin? Cocaine does. People use cocaine to self-medicate depression. People use alcohol to self-medicate ADHD. In one study, 40% of male alcoholics were shown to have ADHD. It calms down the brain, the hyperactive brain. So does marijuana. A lot of kids will tell you that I smoke pot, I can listen to the teacher better. And they're telling the truth, because it calms down their brain. Now, they can listen better. What they'll remember is another story. Because I'm not advocating cannabis as a treatment for ADHD, but subjectively, they do get some relief. So in that sense, it's a self-medication. People self-medicate PTSD. PTSD with what? With the opiates. The opiates are powerful modulators of the symptoms of PTSD. Now, there was a study. I've been maintaining this for years. I don't know how to say this without sounding terribly arrogant, but everything I've been saying seems to be proved by studies all the time. And it happened this morning. They looked at PTSD cases. You know what predicted PTSD? Not the war. This is amongst veterans in Iraq and Afghanistan. You know what predicted PTSD? Not what happened in the war. We think that PTSD is because of what happened in the war. You know, like Romeo Dallaire, the Canadian general, his PTSD. Everybody thinks his PTSD happened because of what he witnessed in Rwanda. Nah. What predicts PTSD is trauma in childhood. What happens is that the trauma in childhood simply gets triggered by them, what you experience as an adult. But if you weren't traumatized as a child, you can go through those experiences as an adult and not be traumatized at all. So again, we come back to what happened in your attachment relationships. So people self-medicate PTSD with the opiates. People self-medicate anxiety, of course, with the drugs. They medicate social anxiety, the guy who can't interact and feel confident socially without having a few drinks first or a shot of cocaine or crystal meth. So on a very simple medical level, on a narrow medical level, addictions are self-medications. So just to tell people to give it up without looking at the underlying conditions is obviously unsatisfactory. But looking deeper than that, when I say the narrow medical level, the medical perspective, there's nothing wrong with the medical perspective in what it says. Mostly what's wrong with the medical model is what it doesn't say. And the problem with physicians, by the way, I maintain, is not that they think they know everything. They don't. They're very humble. It's not that they think they know everything, but what they think they don't know is not worth knowing. That's what the problem is. So that we don't look at the larger picture. So the neuromedical perspective on addiction is quite accurate, but it misses the point because there's so much more to it. Now, if you look at addictions from a brain perspective, why is it that the drugs work in the human brain? So opiates, for example, have been known to medical practice for thousands of years. In Chinese medicine, Middle Eastern medicine, they've been used for a long time, used for pain relief. They're the most powerful pain relievers that we have, and anybody working with palliative care patient is very grateful for the presence of opiates like morphine and Dilaudid and so on, in the codeine, in the treatment of pain. But opiates don't only soothe physical pain, they also soothe emotional pain. Because it turns out that the same structure in the brain that experiences the suffering of physical pain also experiences the suffering of emotional pain. When people are undergoing brain scans, and while they're under the brain scan, you subject them to an experience of emotional rejection, the same part of the brain will light up as would light up if you stuck them with a knife. Pain is pain. And the language recognizes that because we talk about a painful comment or a hurtful experience or a stab in the heart. What you said hurt me. It gave me a lot of pain. It did, because you're experiencing emotional pain in the same part of the brain as you experience physical pain. That's not strictly true. It's the suffering is experienced in the same part of the brain. And that part of the brain is richly endowed with opiate receptors. So that the opiates are powerful pain relievers. In fact, if you look at the drugs of abuse, they all are pain relievers. Alcohol, as you know, is a pain reliever. Before the days of anesthesia, you've seen these cowboy movies, you know, the guy gets a bullet in the leg, what do? Before they dig it out? A shot of whiskey. What's the expression that we use when somebody is drunk too much? It's kind of a wry expression. We say, oh, he's feeling no pain. Cocaine is a local anesthetic, still used that way. And in one way or another, all drugs are used to numb your feelings or to escape from emotional distress. And that means, by the way, as my mantra says, that the first question in addiction is not why the addiction, but why the pain. And if you understand why people have pain, you can't look at their genes. You can't look at choices. You have to look at their lives, their actual life experiences. If we go deeper and we ask, why is it that these medication or these drugs even work? Well, why is it? Why is it that you take an opiate that grew in Afghanistan and you take it here in Canada and it has such a powerful impact on your brain and your body? Well, of course, the answer is because we have receptors for the opiates. Now, receptors, as you know, are chemical binding sites on the surfaces of our cells. So each cell has tens of thousands of receptors for many different kinds of messenger substances. So if my head is a brain cell, then there might be a receptor that looks like this, you know, thousands of these. There might be thousands of these, you know, all these different configurations of receptors. And to each kind of receptor, a different chemical can bind. Oh, by the way, Bruce Lipton, a molecular biologist, asked a brilliant question, which I totally flubbed when he asked me this. As a medical doctor, I totally flubbed it. Let me ask you this. Remember the picture in high school biology of the human cell? There's this sort of square with the membrane around it and the cytoplasm, this gelatinous material that fills up the space in the cell. In the center, there's the nucleus. Now, what if I ask you, what do you think is the brain of the cell? Or what would you say? What would anybody say? The nucleus, okay? And how many would agree that the nucleus is the brain of the cell? Just, okay, put your hand up if you agree. Who would say anything else? Any other opinions? Yeah? The outer layer, the membrane. And why do you say that? Say that again? You're totally right. I also said it was the nucleus, but actually it's the membrane. Because the part of our body, our brains have the job of receiving messages from the environment, telling the body what to do, and then taking the messages from the body and communicating them to the environment. That's done by the membrane, not by the nucleus. The nucleus is simply the gonads of the cell. It contains the genetic material. But what happens is that messengers from the environment come, they fit into the receptor, and together the messenger and the receptor then create an interaction or a reaction in the membrane that then sends a message to the nucleus, telling the nucleus what to do. In other words, the genes are turned on and off by the environment. And that's why the idea that so many of the diseases are genetic is so false, because genes are turned on and off by the environment. So we have receptors for opiates. But why do we have receptors for opiates? Why do we have receptors for a product that comes from a plant in Asia? We have receptors for them because, well, we don't actually. We don't have receptors for opiates from a plant that comes from Asia. We have receptors for opiates that our own body manufactures. In other words, our own body makes the very same substances, or very similar enough that they look alike, so that the receptors are fooled. Now, why do we have an opiate system? And by the way, our opiates are called endorphins. Endorphin means endogenous morphine-like substance. Now, why do we have opiates? Receptors. Because they play an important function in human life. In fact, they play 3 important functions. Many important functions, actually. But in the brain, the 3 major functions are, number 1, pain relief. Number 2, the experience of pleasure and reward. So without opiates, we have no sense of reward. Whenever you're happy, joyful, elated, it's because you have endorphin flow, opiate flow in your brain. And number 3, they play a function, they play a role without which life is not even possible. And that role is, in a word, love, attachment. Remember I talked about the importance of the attachment relationship, without which life is impossible. Well, it's the opiates that saliently make love possible. Whenever there's an attached, attuned interaction between a baby and a parent, they have both endorphins flowing in their brain. That's why parents get addicted to their kids, because they love that endorphin flow. In infant mice, when you knock out their opiate receptors, endorphin receptors genetically, these little mice will not vocalize distress. They will not cry for their mothers on separation. What would that mean in the wild? Their demise, obviously, because only the presence of the mother sustains the life of the infant. In other words, the opiate addiction takes hold in a brain circuit without which life is impossible. You want to know why people have such a hard time giving it up? Imagine in your life, if you had no sense of pain relief, you had too much pain, if there was little sense of reward and joy, and furthermore, not much of a sense of connection. And all of a sudden, you had this chemical that would give you all these qualities. Now, how would you give it up? Would it be sufficient for somebody to put a sign on the wall saying, just say no? Just say no to love and connection and pain relief. One sex trade worker, a 27-year-old woman, told me, the first time I did heroin, she said, it felt like a warm, soft hug. And others have told me the same thing. So that's the opiates. I've already mentioned the stimulants. In another mouse experiment in a laboratory, you take a pellet of food and you put it in the mouth of this little mouse who will chew it and swallow it and enjoy it. But if you put the food down inches away from his nose, he will not stir to eat it. In fact, will starve to death. He's quite capable of movement, but he won't. Why? Because genetically, they knocked out his dopamine receptors. Dopamine, that chemical which is elevated by the stimulant drugs, is our incentive motivation chemical. Dopamine flows whenever we're excited about something, motivated, when we're curious, vital, vibrant, feeling really alive, when we're seeking food, seeking a sexual partner, exploring a novel object or a novel environment. These are states of high dopamine flow. Without dopamine, we're listless, not motivated, and apathetic. So imagine then that somebody then gave you a substance that all of a sudden, poof, you feel totally alive and life is exciting. How would somebody take that away from you? By putting a sign on the wall saying, just say no? And really, what you might have divined by now is the question that I'm asking is, who is susceptible to addiction? Because what is clearly not true is that drugs are addictive. Drugs are not addictive. Not by themselves. If drugs were addictive by themselves, we couldn't give morphine in large quantities to large numbers of people. But in fact we do, and they don't become addicts. Is alcohol addictive? Clearly not. Most people who drink alcohol, even repeatedly, even in relatively large quantities, don't become alcoholics. They don't become addicts. Is food addictive? Clearly not. Human beings have been eating forever without being food addicts. But to some people, it is addictive. Is a pack of cards or gambling addictive? Not to most people. But some people become hooked on it. So the question we have to ask is, what makes some people susceptible? The whole idea that drugs are addictive is total nonsense. Most people who try even crystal meth, and crystal meth is a very powerful drug. You know, sex will elevate your dopamine levels by 100%. Pretty good. Cocaine by 300%. Crystal meth by 1,200%. So, one patient told me that crystal meth is like an orgasm without sex. But even then, most people who try crystal meth, the vast majority of people who try crystal meth, even repeatedly, don't become addicted to it. I'm not advocating that anybody should try it or use it. All I'm saying is that it's not true that by itself it can cause addictions. So clearly what you have to have is a susceptible individual and a potentially addictive behavior. And by the way, what is a potentially addictive behavior? What is a potentially addictive behavior? The answer is anything. Anything. My definition of addiction simply says, an addiction is any behavior that you crave, that gives you temporary relief or pleasure, that has negative consequences, and you can't give it up despite the negative consequences. Nothing about substances. It's any behavior, substance-related or not, that gives you temporary relief and pleasure, that you crave, and that you engage in despite negative consequences, you're not able to give it up. That's what an addiction is. Clearly, you can be addicted to gambling, to internet, to shopping, to work, to sex, to sports, to the acquisition of wealth, to power, and to substances. As a matter of fact, when you look at the brain circuits involved in addiction, whether they have to do with any of these behaviors or with substances, it's exactly the same brain circuits that are involved. Shopping addicts get the same dopamine hit that the cocaine addicts get, except they get it through the shopping. So the shopping addict is a chemical addict, except the chemistry is internally generated through that particular behavior. Same with the gambler, same with the sex addict, same with the workaholic. So that whether you're looking at biochemically or psychologically, addictions all fill the same role in people's lives. It's just that in the case of the substance addict, they have to get a substance. And then the question is why? And so this is where I'll stop for a moment, and then I'll come to some of these answers. But I'll just stop right now and see if there's any questions or comments on anything that I've said so far.